Hello everyone, and welcome to the newly refurbished Liz Cantel room for this evening's meeting. So this is the second meeting of the Health and Adult Social Services Standing Scrutiny Panel of the civic year. As you know, I'm Ben Wesson, chair of the panel, and I'm being supported today by Anna Marie from Democratic Services. Today's meeting is being held in a hybrid format. So we do have Councillor Steed, my vice chair, who's joining us online. We're also expecting a member of the public to join online as well to ask some questions on one of the items. Can I just remind all colleagues that we are live streaming on YouTube, so no swearing, please. And if Councillor Steed, because you're the only person online, if you have any questions, if you can just make sure that you raise your hand and we will bring you in, that will be just fine.
Thank you very much, Chair.
No problem, and we can hear you loud and clear, Councillor Steed. So just to make colleagues aware that this evening's meeting will be Anthony Brooks' last meeting because you are moving out of the borough. I think that's right, Anthony, and stepping down from your role. But can I just say, on behalf of the entire panel, thank you for all of your work over the past year. It's been really very much appreciated, and looking forward to your contributions to tonight's meeting. And we will be working with EHCVS to find a replacement for you. But thank you very much. Apologies for absence is item number 1 on the agenda. I haven't received any apologies from councillors. I think we've got a full house, which is great, but we do have apologies from Carleen Duffy from Health Watch Ealing. Carleen's being substituted tonight by David Crawley, who's a familiar face to colleagues in the room, so welcome again, David. We'll move on to item 2, which is urgent matters. I don't have any urgent matters of business this evening, which means that we can move on to item 3. Oh, Councillor Steed, sorry.
Chair, I'm not sure this is the right time, but you and I have spoken outside the meeting concerning an issue to do with the Michael Flanders Centre. And I know that I think I'm looking at the back of Kerry Stevens as I speak. Yeah, okay. I would like, I've received a letter from a constituent, as I believe has another ward councillor in the meeting, concerning a review of the Michael Flanders Centre. That may be too strong a word, but I'm wondering if that could be addressed as an issue, or maybe it goes on the panel work programme for future discussion.
Thank you, Councillor Steed. I was intending to pick that up under the panel work programme item, if that's acceptable to you.
Yeah, no, that's fine.
Lovely, thank you. So item 3 on the agenda is declarations of interest. Shall I get us started as normal? So my employment is with the Nursing and Midwifery Council. Councillor Conti.
Yeah, I'm a GP in North West London.
Any more for any more? I think that is us done on declarations of interest. Thanks very much. Matters to be considered in private is item 4 on the agenda. There are no matters to be considered in private this evening, so far as I'm aware, which brings us to item 5 on the agenda, which is the minutes of our previous panel meeting. Do we agree that the minutes of the meeting held on the 5th of September are a true and accurate record? Thank you very much. Which then brings us to item 6, which is the panel work programme. So I had a very helpful number of one-to-ones with co-optee panel members, and thank you to the co-optees for indulging us. I think they were really useful sessions to understand kind of the history of how the panel's operated and also improvements that we can make for the future. So I just want to record my thanks, and we will be looking to set up one-to-ones with other panel members that wish to have conversations with myself and Anna Marie, just to see how you're finding the experience of the panel and if there's any improvements that we can make in the future. Specifically on the work programme, so the Safeguarding Adult Boards report, you'll see that has changed from this meeting this evening to the March meeting. That's to enable some further work to be completed on that report. I was asked a question from the Ealing Reclaim Social Care Action Group in respect of the CQC inspection of adult social care and when that report would be made available. It's not publicly available yet, and it's not clear when it will be, but one thing I can say very firmly is it will come to this panel for us to look at as a scrutiny panel. Other things to point out, a report on the Careline service is scheduled for the May meeting of the panel, and we will have a visit to the Careline in April for panel members that are interested in going over to Harrow for that. And then a few more things. The North West London Joint Health Overview and Scrutiny Committee meeting took place on the 22nd of October. Members considered the communications and engagement strategy for the public consultation on the new model of care for community-based specialist palliative care services, the development of the mental health strategy for adults, and the North West London Primary Care Access Engagement Plan, obviously the latter being on the agenda for our meeting this evening. The next panel meeting is scheduled for the 5th of December, and I'll be able to circulate an update following that. As chair of this panel, I've also been invited to participate in a joint health overview and scrutiny committee that's being hosted by Hertfordshire County Council, and that will be considering the proposal for moving the Mount Vernon Care Centre from Hillingdon Hospital to Watford General Hospital. And you may be thinking, well, why does that concern Ealing? Obviously, a number of our patients will be affected by that change, and we have a meeting this Friday to determine the appropriate level of involvement for us as a council. So I'll be able to again provide an update following that meeting, but if any panel members wish to raise matters with me in relation to that, very happy to take representations from colleagues. And then the final thing, which Councillor Steed already referenced, was in relation to the Michael Flanders Centre, and my suggestion in response to Councillor Steed's proposal is that we factor some time into our work programme for a conversation around that at a later date, and that Kerry and I can, and Councillor Steed as the Vice Chair can talk about when that would be most suitable for coming back to the panel. Councillor Daniel Crawford.
Chair. Yeah, just on that last point, I've also received from a constituent a copy of a letter, which I assume is the same letter that Councillor Steed is referring to, that's signed by Mr. Stevens, that talks about inviting residents to 3 drop-in sessions, one at the Cowgate Centre, one at the Michael Flanders Resource Centre, and then a 3rd online session. And judging by the dates, the letter dated the 11th of October, judging by the dates of this letter, these sessions have already occurred. So I'd be very interested if the report could tell us why these sessions occurred, why this committee was not informed of such proposals, as in previous years. We certainly were, Chair, and you'll understand why I know why we were informed of these proposals, and what was discussed in these sessions and what is likely to be discussed further. And I'm happy to make sure that both you and Councillor Steed have sight of the letter that I've got to compare whether it's the letter that you've got and whether it's the letter that Councillor Steed has got. And obviously, I'll take you at your word that we will have a report and we'll have one as soon as possible. Thank you.
Thanks, Councillor Crawford, and I'm very happy to take those issues away so that we can make sure that the future scrutiny item addresses those things. So thank you for raising that approach, and we will come back in due course with an update. Thank you. Any other comments from colleagues in relation to the work programme? In which case I'm proposing, now I have promised both Neha and Vijay that they will be up first, because what tends to happen at these meetings is they end up being tagged on to the end, which is definitely not the message that we want to send to our health partners. So I am going to hand over to Neha, our Borough Director, and Dr. Vijay Taylor, the Borough Medical Director, to introduce this report. The report is on the North West London Primary Care Access Programme. You're going to provide us with an update on revised plans to improve access into general practice and the engagement approach that's being taken. And then we have also Dr. Shergill, who is from the Ealing Local Medical Committee, and I'll invite you to make any comments following that, and we'll open up to panel questions too. Neha and Vijay, over to you.
Thank you very much. So this report was requested some time ago when we previously bought a paper on the access programme, the programme to try and improve general practice access. It's fair to say that that piece of work wasn't well received some time ago by residents, our practices, and various stakeholders. And we agreed to, as an ICB, to pause that programme and reset the programme in order to take some of that feedback on and really think about how to engage with our local residents and practices and put our practices in the driving seat for improvement in access. This paper summarises what we have been doing since then and what the next steps are at the moment. At the last scrutiny committee where we discussed this paper, the recommendations and from the joint health overview and scrutiny committee were agreed as well, and we had an additional couple of asks from the in Ealing perspective around the Northolt pilot and things like that. So in the paper, in the front page, we've got the responses that were provided to the joint overview and scrutiny committee on all of those recommendations. I'm happy to take any questions on all of those. But in addition, we've added a bit of information about the Northolt pilot that had been running in Ealing. They started in November 23. It's Appendix 1 of the main paper. They started in November 2023, but following all of the feedback and their learning, they decided to pause their programme as well. The summary of the hub-based model that they were running is in the paper itself, but we didn't get to the point where Northolt were able to do an evaluation that was meaningful. Also, because of the pause in the programme as it currently was, we haven't had a full evaluation of how the models were working elsewhere, but instead we've taken a step back. And we have supported our practices and given them an incentive through a contract to run a patient survey and a number of events with their local patients on what the feedback is around access. What is very clear, and I think we've heard through various Health Watch reports, national surveys, local surveys, is that when a resident or a patient gets through to a GP, they're really happy with the care that they receive, overwhelmingly. It's the getting the appointment has been the problem. So the approach that has been taken is to establish a survey that is run and delivered via the primary care network. So they are out there trying to get our residents to fill the survey in. A set of core questions were developed with input from patients, the LMC and our communications team. And then the PCNs were invited to add a couple more questions that are more local to them as a primary care network. In addition, our communications and involvement team were there to support our PCNs as required, or advise and guide them, and also discuss the access survey through various engagement events that they were running as well. Then each PCN would host 2 local events to talk about access, one face-to-face and one digital at least. And also a survey would be run with their staff as well about what their thoughts are on improving access. The second stage of this, so all of this will be collated and analysed, and I've given some dates on there, but we had extended the survey by an additional week to what the dates were in this paper, because this had to come out slightly ahead, and the analysis is being done centrally. In addition, so once the analysis then goes back to the PCNs, they can then run their physical events with the patients to really understand what the feedback was. Part 2 of the programme is then for the primary care networks to come up with a case for how they would want to improve access in general practice and for their PCN. That might mean a same-day access model, that might not be. That might be a hub, that might not be. It really depends on the feedback that they receive from their local populations. So I think I will stop there and hand over to Vijay, with Dr. Taylor, if he wants to add anything to that.
Yeah, just to add, in terms of the engagement programme, we do believe that could be very successful in terms of the responses that we've had back from the public of North West London. I haven't got the final responses, because there are clearly some responses which are being submitted manually, which then they need to be inputted into Bang the Table. But as of last week, we had circa across North West London around 82,000 responses. So our expectation was around a 5% response rate, which equates in relation to the population that is able to complete the survey, circa about 90 to 100,000. So I do believe we're probably going to hit that 90 to 100,000 response for the first part of that engagement exercise. I think what's important to understand is the questions that we developed as part of the survey, as you can see in the papers, they were very much a lot of free text questions, because we really wanted to get the richness of the feedback from the public. And there were questions about how we'd be able to analyse free text questions. And Bang the Table, the platform that we have used, has quite sophisticated AI functionality to able to process free text answers from the responses, and the team centrally are currently working through that process, and we will be there will be an expectation and a commitment to have 45 individual PCN reports from the initial engagement exercise. Clearly, this is just one part of what we're trying to do here. We do believe that 2 interactive engagement exercises are just as important as the questionnaires, because it's important that we reach out to all of the communities across North West London, and particularly in Ealing, we have a very, very varied community. And so the opportunity to have interactive engagement exercises, one face-to-face and one virtual, is going to be very, very important. And our PCNs are now working through those dates and the logistics to manage those 2 interactive exercises. And then The feedback from all of the engagement will then be used and put together in a final engagement report for each of the PCNs to support them, and information that is available to hand to then consider how each of the individual practices within the PCN and the PCN as a whole would like to consider how they want to try and look at access into general practice going forward. The expression of interest business case, which is the phase 2 or part 2 of for this year, that process is about to go live, and the PCNs will be able to then put their business cases to the ICB for this financial year, because as we always had said, that we want to ensure that the investment for access into general practice goes back to the single offer for 25-26 and onwards. As you know, we took it out of the single offer because of the feedback that we had received to ensure that the rest of the single offer for the enhanced service could continue and progress. But our key aim is to get an access specification for 25-26 onwards back into the single offer, so that investment of just over £6 million can then continue to be invested in access for the residents of North West London.
Thanks very much, Dr. Taylor. Dr. Shergill, appreciate your comments.
Good evening, everyone. Thank you for asking me to come along to give the LMC GP view. Thank you, Neha and BJ, for that update. Yes, we have had a reset. It's been a long time coming, and where we've got to was a better place. However, the implementation of the access program has been fraught with complications. We were glad to see same-day access hubs and non-GP activity being dropped from the commentary. Patients tell us they want to see GPs, and there was a British Journal of General Practice survey research paper out very recently, which showed that same-day access is directly linked to poor patient experience, and also what does correlate with good patient experience is seeing a GP. So that goes in line with what we've all been saying all along. However, the survey we felt was leading in terms of continuing to have an undercurrent of working with a hub, with working at scale and utilising non-GPs. Some PCNs reported their input into their questions for the survey were disregarded. Some PCNs did have their questions accepted. Last week, I think the figures suggested over 300,000 patients, PCNs, weren't involved in the programme, but as my colleague has said, everybody has now signed up, and I think there's a degree of pressure to participate in this, which is not a great way of engaging people. Part 2 was something which we were meant to receive this week, and we still are not in receipt of that. And the issue with that is that we are now heading into winter, and where we should be focusing on winter pressures, we are now being asked to submit a business plan which will take away people from delivering care to patients and instead building a business case to take forward the funding for the £2 a patient. The difficulty we face with that is there's no clarity as to what expectations there are that a business case will be successful. And the concern is that a lot of people will put a lot of effort in knowing that that will be forlorn effort. And the concern thereafter is that we are losing investment into primary care to provide access to patients. So there are still concerns about how this might go forward. Compared to where we were this time last year, I think we're in a better place. However, I think there are a lot of concerns, and it's unclear how the phase 1 and phase 2 are actually linked together in this scheme, because it's meant to be a linked scheme. They appear to be two separate schemes. And the last point that I'd like to make is it's unclear how this year's access proposal is going to impact on the single offer access proposal for next year.
Thank you very much for those comments. So I've had indications from Councillor Daniel Crawford and Councillor Raza, and then I'll come to you, Councillor Conti. We'll do it in that three. Over to you, Councillor Crawford.
Thank you, Chair. I feel a strong sense of deja vu with regard to this particular item because we've been here before, and I know all of the speakers who've spoken will recognise that fact. I would firstly like to entirely endorse most of what Dr. Shergill has said, because the feedback I've had from practitioners is largely along those lines. I'm very grateful that the sort of KPMG experiment as well seems to have been shelved. Chair, I don't really know what KPMG were bringing to the process, except costing the residents of North West London more money in an already tight financial envelope. I do have concerns in respect of the same-day access and the hubs along the lines of what Dr. Shergill has said. I'm very grateful that some of that has been altered in terms of the direction of travel, and I note that the report is correct in saying that this panel has previously endorsed that direction of travel when we've looked at this previously. I guess my questions are around the two questions. Firstly, on the survey itself, some of these questions are indeed very leading, or at least, you know, they don't give much opportunity to garner a true flavour of wide responses to particular questions. I understand that the open questions, as Dr. Taylor has outlined, give an opportunity for respondents to write their own thoughts, and that's very welcome. But some of the other questions are, there is simply no way to answer some of these questions other than in one particular fashion. And I would say as well, I completely endorse this idea that phase one is supposed to lead to phase two, but phase two is reliant on a business case being put forward. And Chair, we've been here before with business cases for this type of thing. Some are successful, some are not. It's not in the power of Nahar and Dr. Taylor to ascertain which business case would be successful. If it was, we'd have a much better scenario. And I'm very concerned, frankly, that a lot of people, including ourselves, will put a lot of time into a survey, perhaps the most wide-reaching survey since our own council survey on shaping a healthier future. And we will be still in the same position of not knowing what can be funded, how quickly it can be funded, and how many patients will be able to be left out of winter pressures. And I completely endorse finally the point made last by Dr. Shergill very effectively, which is my constituents want to see the same GP, or at least have confidence that they're going to be able to continue their care with the family doctor or the same GP. And I'm very concerned that through no fault of Nahar or Dr. Taylor, what we're actually doing is forcing a position where we have locum GPs, or worse, not even GPs at all, carrying out some of these assessments, when we need a better connection between our patients and the people they trust, which are general practitioners. But I'm going to stop there, Chair. Thank you.
Thanks, Councillor Crawford. I think we'll just pause there because actually there were about, I think, 5 different issues. So there's something about KPMG in there, the survey questions and the leading nature of them, the kind of linkage between phase 1 and phase 2, the kind of what will be funded, how it will be funded, package of questions, and then that point around kind of continuity of care and seeing the same GP. So I think that's enough to get us started. Thanks, Councillor Crawford.
I'll start with this. So just try and answer those questions one at a time. So I'll start with the KPMG one. So the the ICB decided to bring KPMG in the summer of 2023 to work with the early adopter PCNs, looking at how modern general practice can change, particularly working in collaboration of member practices within a PCN and looking at ways of managing the low acuity same day access. And this was really stemmed from the Fuller report, where Fuller in that report describes how you can do a level of segmentation between same day low acuity activity and much more complex long-term disease care, and trying to segment that in a way that makes it efficient, and so that continuity of care for your long-term disease management is not compromised. The work with KPMG did stop, and we parted ways at the end of March 2024, and the outputs from the KPMG, actually some of the outputs was very useful, particularly in terms of looking at how general practice is delivered, not just in this country but across Europe and wider, in terms of some of the models that are available, but also in terms of looking at the level of demand into general practice and looking at the WSIC data to try and understand where our public are accessing general practice 24/7, because there are various ways that they can access general practice, including our urgent care centres, A&Es, GP surgeries, walk-in centres, PCN Saturday hubs, etc. So we needed to get a better understanding of how we can manage that going forward. With regards to the questions, we gave every PCN opportunity to submit 2 additional questions over and above the core questions. It was absolutely important from an ICB perspective that we had to have a set of core questions, because if we had complete free-for-all for every PCN to devise their own questionnaire, the ability to then process that would be unachievable. You know, in terms of the resource available to try and process 45 different types of questionnaires, it at this scale would not happen. So we had to have a core set of questions and the opportunity for each PCN to submit 2. Not every PCN submitted 2 of their individual questions. Yes, some PCNs asked for 6 or 7 or 8 questions, and clearly we weren't able to do that in addition to the core ones. So every PCN was given that opportunity, and that's really important. I think what's important to understand is that the survey is just one part of the engagement journey. It's going to be really important that the PCNs put some effort into the engagement exercise, because it's clearly important that not everyone will have the ability or the scope to be able to complete a questionnaire, and their opportunity to give feedback is very important. Yes, we spent a lot of time in our task and finish group to try and work through what would be the core questions. No questionnaire is absolutely perfect. You know, we had, you know, potentially if you have 100 people around a table, each of them will come up with a different set of core questions. And so we had to be quite pragmatic to ensure that we have a blend of option type closed questions as well as the free text ones. And I think the free text questions are really the most important ones, which we believe is the way that we're able to understand the experiences of our population in terms of access into general practice. In terms of the phase 1 and phase 2, it's absolutely important for PCNs to appreciate, to be able to assimilate and be able to understand the feedback that they are getting from the public that they serve. You know, as I said, this is one, you know, in terms of the response rate, we've excelled, I believe, in terms of the level of responses that we've got back from the public. We will have over 90,000 responses across Northwest London. That level of feedback has never been done before from a general practice perspective at a local ICB level anywhere in London. I don't think it's been done anywhere else across the country. The phase 1 or the part 1, it does feed into the expression of interest business cases, because you need to be able to understand and listen and consider what the public are saying about access into general practice. in terms of understanding how you want to take access going forward. General practice is changing. Modern general practice is about how general practice care is delivered by a team, not by a single GP. Not every single GP can see every single patient. We know within general practice, chronic disease management is managed by a team of clinicians and individuals. If you go for your diabetic review, you will see a phlebotomist who will take the bloods. You will see a healthcare assistant who will do your foot check. You will see a clinical pharmacist or a GP who will do the medication changes and the overall diabetic review. General practice is very different to what it was previously. We have an expanded workforce in general practice as part of the ARS PCN workforce. And these are professional individuals, allied professionals, social prescribers, physios, paramedics who are working with GPs to manage the health needs of the population. So when we say that our residents want to only see their GP, the residents need to understand that the GP works within a team, and that's the way it is. And that's the way it's going to continue to go across the country as the general practice and the primary care workforce is expanded. Finally, in terms of the business case, yes, there has been a level of delay in terms of rolling out the business case. And yes, the timing is not perfect because we are coming to winter. There is significant winter pressures. We understand that. The reasons why there was a delay is the ICB wanted and needed to be assured that the investment of the £2 per patient was bringing some level of value for money. And that was so important for the ICB in terms of the business case. There are three elements to the business case which is important to understand. One is about quality improvement, the other is about change management, and finally the value for money. And all three of those have an equal weighting in terms of the success of the PCNs with regards to their expression of interest. The expression of interest is going to be sent out to all of the PCNs tomorrow. Yes, it was meant to go out today. There was just some final logistics that need to be sorted in terms of the contracts, and they are going out tomorrow for all of the PCNs. Some PCNs across Northwest London will complete those business cases prior to having the final feedback and engagement from the public. And that's partly because some of our PCNs across Northwest London already have a model of primary care access working in a collaborative way. And so they are, in some respects, slightly ahead of the game in terms of what their thinking is. But the others will wait for that feedback to come through. They will then use that feedback in the engagement exercise to then support them in their business cases. You know, we want, as an ICB, we want that money to be invested into general practice. That's always been our priority. And it's important that that total investment of the 50p for the engagement and the £2 for the expression of business access business case, each of our PCNs gets that money. That is what we've always wanted to do, and we've always try and ensure that happens. However, as an ICB, it has a level of responsibility in terms of ensuring that there is a level of value for money.
Lovely, thanks very much, Dr. Taylor. Mindful that there's quite a lot of interest from colleagues, so I'm going to take Councillor Raza, then Councillor Conti, then Councillor Kate Crawford, and then we'll come to other colleagues after that. But could I ask for short questions and short answers? We've got 20 minutes for the remaining questions here.
Okay, thanks, Chair. I'd like to focus a bit more about how inclusive the survey is. I'm assuming that it's in English and not in community languages. How are we making it more inclusive for all? As Nehad pointed out, that we're a very, very diverse borough. We need to make sure that we're reaching everybody in our community and are getting the feedback and the engagement that we need to get from everyone. So I'd like some expansion on that, please.
Thanks, Councillor Raza. Councillor Conti.
Thank you. It was just sort of following on from Councillor Raza about sort of access to the survey. I was contacted by a resident today who saw this was on the agenda, who said that they'd actually tried to contact their practice as well about getting it. The practice got their email address and their mobile number, and they never received a survey. So is there a way for residents who want to engage but haven't had an opportunity to? I know the deadline obviously is closed, but that they still can. And how are we monitoring to ensure that, I know you've said about 90 to 100,000 back, but that, you know, there is a sort of all PCNs are represented, you know, and there's been a sort of a good number of responses sort of everywhere. And my second question is about the Northolt pilot. I was just intrigued about the no evaluation took place. Obviously it was a 5-month programme that ended in March. Obviously public money went into that. You know, there was a trial or, you know, a model that was tested. Aren't there lessons that could be learned, and why was no formal evaluation took place? It just seems a bit odd to me.
Thanks, Councillor Conti, and Councillor Kate Crawford.
What I would like to hear from the practices in this survey is the person feedback from the person you actually speak is trying to get an appointment, because they're the ones that try and deal with the concerns and ask you to do different things, anything to avoid seeing a GP, and are unable to address problems, perhaps with the hospital, that kind of stuff. So you did say that there was going to be some feedback from the staff, but we learn an awful lot from social services complaints, and I'm just wondering whether you've considered for 1 month where all the staff who are actually, the receptionists on the phone, they just document what the concern, not necessarily complaints, but what the concerns are, what the problems are, and then that will give you so much more, or different kind of information, because I think there is a problem with people seeing this, and are they going to go through, those people are going to be using this service perhaps more a lot, the older community, are they going to go through this? Because it doesn't, this one where it says collaborate with other surgeries. Well, if there isn't a transport there, then they're not going to know linking from one surgery to another. They're not going to be able to answer that question. I think that is a bit of a leading question. So thank you.
Thank you, Councillor Crawford. So we had a question from Councillor Raza about accessibility of the survey questions. Councillor Conti covered off some patients not receiving the questionnaire and what alternative engagement we might make available to them. A concern around were all PCNs really truly represented. A bit on the Northolt evaluation. And then are we doing anything to kind of capture that informal feedback from sort of receptionists and wider surgery staff?
Okay, so in terms of the diversity, you're absolutely right. It's important to try and be as diverse and inclusive as possible in terms of any survey that we roll out. Yes, you're absolutely right. We weren't able to develop a bang the table survey in multiple languages. It just wasn't possible. We just didn't have the capability or the functionality to be able to do that. What we've asked PCNs and the individual practices who serve the diverse population to use their local intelligence and their local processes that they have continued to use to engage with the local population in terms of the languages that these individuals speak. What we've done in some areas, in fact, is that some of the staff members within the practice have actually supported the residents to complete the form, and because it's not just an electronic form, our residents are able to complete a paper form as well and submit that back to the practice receptionist, because it was important for them to be able to do that. What we've also done is because this was a engagement exercise targeted at the PCN level. Each PCN would then disseminate the information and the surveys and the process to all of their member practices. Yes, I do know that there are some practices within a PCN that may not have sent out that survey. It was for the PCN to ensure that each of their member practices sent out that survey. What we have done across North West London, we also put the survey on our North West London website to allow residents to complete it who have not received an individual survey link via text or other means from their individual practice, because we knew that this was the case. Clearly, the ICB couldn't mandate that every practice send out that survey because this was a PCN level engagement contract. It was up to the practices and the PCN to decide how they're going to disseminate it. But saying that, as I said earlier, we've had a encouraging positive response. The other aspect around diversity inclusion is our engagement outreach team have been doing a lot of community work across North West London at various community groups, and they have been promoting the survey when they've been going out into the local resident populations to try and ensure that as many people complete the survey as possible. Yeah, no,
and I think there was the issue around the kind of Northolt feedback and also kind of the informal feedback channels.
Yes, thank you. I was disappointed as well, to be honest, when I couldn't get an evaluation from the Northolt PCN. What we did hear from the PCN is the model that they had developed was almost like a roving clinic around each of the practices. So for a couple of weeks, it will be one practice running these additional clinics. Another couple of weeks, it will be another practice. That obviously did not work for them, and they felt that it added additional work onto a very stretched workforce. So it didn't work for them, and that's why they paused it. But I wasn't able to get, partly because of capacity and expertise within the PCN, they weren't able to develop an evaluation, I'm afraid. And in terms of the practice staff and that idea about asking the practices, we're definitely going to do that staff survey, and I think that's a really important part of the whole puzzle. But I think it's a really interesting idea, and this is a stage in improving access. Trying to improve services is an ongoing agenda, and the quality improvement process is an ongoing agenda. So we can definitely suggest that to practices and PCNs for the future. It's a really, really interesting idea. Thank you.
Just want to finally add about the start. We are doing a comprehensive staff survey across North West London. That again, we're using the Bang the Table platform. We have the survey ready to be rolled out, and that should be disseminated across all of the PCNs and all the general practice staff tomorrow as well, and that will run for 4 weeks.
Lovely. I will come back to you, Councillor Conti, but I've got another 3 questions from colleagues. So I've got Councillor Ty, Councillor Dinser, and then Mr. Cook.
Thank you, Chair. And actually, my question was unknowingly addressed in the very comprehensive answer from BJ. I was interested in the just addressing kind of any digital exclusion or anything like that. But you mentioned that obviously there were paper forms available. So I guess just as a follow-on, was what the uptake was on that would be interesting. I'm just very conscious the artwork is very good and very catchy, and just sometimes, as you say, just making sure we reach certain demographics. I was just really conscious we make sure that we've reached out to everyone, including those who might not be online. Thank you.
Thank you. Councillor Dinser.
Hi, Chair. First of all, my apologies. My understanding of GP working is not as good as some of my colleagues. So my questions are from basically as a customer or patient or as a layman. What I want to know, what are you trying to achieve from this survey, which we already don't know? We know the access to the primary care is due to high demand, GP shortage, heavy workload, longer waiting list, 8 a.m. mad rush for appointments. So what are you trying to achieve? I see one of the questions here. I use the NHS app to order repeat prescription. When a patient goes, one of the receptionists could simply have a chat with them. Do you know of this? I got to know about patient knows best. And all your history is on there. Your appointment, everything is there. Your blood test results, everything. So I tell everybody about it. So what are we trying to get from this survey? In my view, again, silly observation, waste of resources. Because we already know what we, Fuller report, I think you mentioned in here, she came up with the same conclusions. And what I would have actually wanted to know, are we recruiting more GP? How many patients has the patients increased on the GP list? Or how many slots of appointments have we actually increased? Because when you go to a GP, they simply tell you, you can only discuss one condition with us. So there are times when I felt like saying to the reception, I got 3 conditions, book 3 appointments for me. So those are the things we should be addressing. I don't know, but like I said, some of this may sound silly. When we are talking about online consultation through my insurance, I could call a doctor. And when I went to the pharmacist, he charged me for the prescription, £15 something. Am I going to go back again? No, I'll go to the GP because my prescriptions are free. I'm retired. So those are the kind of things we need to look at. But those were some of my observations. I think, some of the time, what we are trying to do, if I can give you a football analogy, instead of 11 players, we got 9 players. No matter where you put them, you are going to leave gaps. So if one GP is you are making him work on Saturdays, he's not working on Thursday, or he's not working on Wednesday. So more GPs. So that was my say. I don't know whether there were some questions in there or not, but that's my understanding.
We're taking the football analogy to the next level. I suppose I ought to be the referee in this debate. So, Mr. Cook, over to you.
Thank you, Chair. What concerns me is you're talking about 90,000 responses. But how was that survey communicated to the public? And in the process that you're actually making the survey a bit biased, because if you're not communicating it properly to the public, people don't know about it. And then you said something that was very interesting. The survey to the public was scheduled to last 2 weeks, and yet the survey to the staff, which there are less staff, is going to take 4 weeks. Surely again, you're introducing a bias within the system.
Thanks very much. So there was Councillor Ty's point around digital exclusion. Councillor Dinser, are we really focusing on the right issues with the questions that were in the survey? And then I think Mr. Cook's raised 2 very valid points around communication with the public, and also a kind of discrepancy or an imbalance between patient and staff feedback.
So thank you. I will start by responding, and I think Dr. Taylor answered a lot of the questions around the community engagement, so I won't go on into that one. But Councillor Dinser, I don't think they're silly questions at all. And actually, that is exactly what we set out to do right from the very outset. We had a lot of feedback. I've been bringing reports to Scrutiny for many years now around primary care access. And what we are doing year on year to try and improve that. Back in 2017, we committed to put more funding into Ealing General Practice to increase the funding flow to allow practices to increase their workforce and recruit the workforce that they needed to deliver all of the appointments. We have had an access specification in that, which specifically asked practices to increase the number of appointments they were offering during that time, and which we were able to measure as well. When this programme of improving general access was first launched, it was based on all of the feedback that we were receiving through the Health Watch reports, through the national surveys, through the engagement that our teams were doing when we were going out to see our residents and in all different community groups, that they were really struggling, and about that 8 a.m. rush, for example. So the whole programme was to try and think about what can we do to address those types of core issues. You've seen a lot of national programmes that have come in place, for example, the NHS app, which allows everybody to have access to their records, but also the prescriptions, and able to request prescriptions, which reduces the demand on practices to do that themselves. It's a sort of a more digital way of doing this. We've had a new programme, and Ealing has got 100% sign up quite early on around patient registration into GP practices being digital as well. It doesn't have to be via digital means, but it's another way to try and improve the bureaucratic work that practices might have to do to increase their capacity and release them to do what they need to do to support their patients. The truth of the matter is the population is growing. The demand has grown after COVID. We've seen a demand on all health services, health and care services, and we've had to respond to that, and we're still responding to that. And primary care has done a fantastic job in increasing the amount of appointments that they are offering. But even then, you have these types of issues like the logistical thing about the 8 a.m. rush, where everybody feels like they have to contact the GP at 8 a.m. to get an appointment. We've had digital consultations launched. So these surveys and doing a reset was because the feedback was that we can't just take all of that and come up with a model of what general practice access needs to look like. And we needed to take a step back, confirm what the issues are that residents are facing, and tailor and ask our PCNs to come up with the approach to improving general practice for their local population based on the needs of their local population, because they do vary across. And that's what this programme is about. That's why we've done this reset of redoing this bit to then do the next stage, which is our PCNs defining what that model of access needs to look like.
Super. And then I think there was the point around the communications with the public, and also the kind of balance between patient feedback and staff feedback.
So in terms of the communication with the public, what we're trying to do here is we were trying to ensure that the PCNs led on the engagement exercise with the population that they serve. So each of the practices within a PCN has their registered list. It was part of the engagement exercise. It's their responsibility to socialise this survey to the residents that they serve, and that's how we decided to roll out this survey, because it had to be via our practices and the PCNs rather than an ICB level survey. As I said, that we have 45 bespoke individual PCN level surveys with the core questions plus 2 questions that each of the PCN decided to include as part of that. And so, yes, as people have mentioned, it may not have reached everyone's doorstep virtually in terms of being able the opportunity to complete the survey. However, we did give the opportunity on our ICB website for individuals to try and do that. The survey, we decided from the outset that the survey will be open for 2 weeks. We did increase it by a further 1 week. The reason why there's a difference between the two is because, as I mentioned earlier, the survey is one part of the engagement exercise. It was important that we had to have a finite time for the survey so that we can get the initial reports back out to the PCNs, so that those reports can then be used to steer the conversations that they have for the 2 engagement exercises. And so there is a discrepancy, and there's a valid reason why that is the case, because ultimately, in the end, you want to try and ensure that the engagement exercise is as holistic as it possibly can. So those 2 interactive sessions, in my mind, are much more important than a survey in terms of engaging with the populations that you serve.
Thanks, Dr. Taylor. I did see 2 follow-ups, one from Councillor Crawford and one from Councillor Conti. If you could keep them short, because we are running to time now. So I'll go Councillor Crawford and then Councillor Conti.
Sorry, Chair, I'll try not to be a naughty boy for a second time. It was just to follow up on 2 things. The first is, maybe there was a mischaracterisation, or I didn't explain myself clearly in one of the questions. I wasn't saying that I was advocating for people to just see a GP and the same GP over and over again. I understand that we need to change the way general practice has historically worked to make it more accessible. The issue is, when you mentioned chronic conditions, I mean, I live with one, and so do many of my constituents. The basic premise of the matter is the current GP practices can't deliver the model that we're trying to get them to deliver, and many residents face really difficult challenges. And I know you know that, but I think it's really important that we structure our communications and are realistic in what we're asking people to achieve in this funding envelope. I just wanted to clarify what I was trying to express. Thank you, Councillor.
No problem at all. Councillor Conti.
It was just to go back about the evaluation for Northolt, and obviously, I hear what you said, it was disappointing, but I can't believe that essentially we commission a pilot with no concrete, absolute way of getting that feedback back afterwards. Because how are you ever going to evaluate the pilot if there wasn't an absolute commitment and way that's done? And with obviously with this new plan going forward, every PCN may have a different model. So how are we going to evaluate further down the road? I understand obviously there's different needs in different areas, but there's clearly going to be good ways and bad ways of doing things, and ways that people can learn. And one of the things you said, Nehar, was that there isn't the sort of specialism or the capability to do that evaluation. Well, how are you going to address that? Because I think that's fundamentally important, because otherwise we're not going to learn anything from this process. And you can have a PCN who's doing it brilliantly, another one who delivers a terrible service potentially. And how are you going to be able to learn those lessons if we don't have the capability to do that evaluation going forward?
Dr. Shergill just caught my eye, so I'll come to you before I go to Nehar and Vijay.
Yeah, I think that's a valid concern. I wanted to amplify a message that I sent earlier on, and that is all the good work that we've been doing since 2017 and how Access was funded in Ealing stopped this year. And my concern is that the business case threshold for rubber stamping a PCN's application to take forward phase 2 is going to be fraught with difficulty, and there will be a lot of forlorn effort and therefore a loss of investment in primary care in Ealing. I'm very concerned about that.
Thanks. Nehar and Vijay, final comments from yourselves.
So I think you make a really important point about the evaluation of the pilot going forward. I think Northolt weren't running long enough to be able to use the metrics that we do have around patient experience, that we have the surveys that we would want to run, for example, or the access data that we have been collecting in Ealing in particular from the GP systems in particular to see if it had made enough of a difference. It just didn't run long enough and in a structured way enough in order to evaluate using some of those things. But I think you make a really, really important point about how we're going to evaluate this going forward. And I think that is something that we have to take away and come up with a solid plan on, and use the metrics that we've got on whether we're going to rerun these types of surveys again, use national information, national surveys, local surveys, the data that we can collect. There's all sorts of things. I'm sure that there is already some thought going into this, and part of the business case process will also be about how we're going to measure that, and that's that value for money piece. How are we going to measure the impact that this is having?
Dr. Taylor.
Yeah, I just want to add one thing. It's important for everyone to understand, and we've learned this lesson, that one size doesn't fit all in terms of how you deliver access into general practice, depending on the various challenges that general practices face in relation to their workforce, their premises, the geography, and also the population that you serve in terms of deprivation. So it's important that when we do move forward from 25, 26 onwards, that we look at an outcome-based specification rather than a process model-based specification. It's about the outcomes that we're looking for ultimately. How the PCNs achieve those outcomes will be determined by the PCNs. And so that's the approach we wanted to go forward, not to be prescriptive by a particular way of delivering access into general practice. It's about the outcomes ultimately that we want to try and ensure that we achieve.
Thank you very much. So in concluding the item, I have a couple of suggestions around recommendations, but happy for colleagues to kind of add to those. I think Councillor Kate Crawford raised an important point about that informal feedback from within practices, and be very keen for that to be taken forward in terms of as part of the kind of staff engagement and staff survey. I think as a panel, you obviously noted that there's a lot of interest from members of the panel, because there's a lot of interest from the community at large about access. So I think we would like to hear what happens as a result of the engagement in terms of the plans that Ealing PCN specifically developed from that engagement activity. And I'm looking to other colleagues for any further recommendations. Councillor Daniel Crawford.
Thank you, Chair. Just this point about phase 2 and the business case is raised by all of all of the speakers here. I am concerned that while the panel has endorsed the approach taken by Nahar and Vijay and colleagues over a long period of time, what we've heard from Dr. Shergill is there is concern from the LMC with regard to maybe perhaps the unintended consequences of front-loading the business case so heavily. I understand why they've had to do it, but I do think that needs to be picked up by this panel to see where that gets to, because otherwise it jeopardises the future investment that Nahar and Vijay and we've all worked so hard to secure. So in considering how we assess that and what the timescales are, I'd like that to be, I'd ask that would be the focus of further work of this panel, but I'll leave it to you and the Vice Chair to ascertain A, whether that's possible, and B, what it would look like.
I think in terms of that specific issue, we've definitely noted the concern that Dr. Shergill has expressed. I would suggest that it's a broader issue than just for Ealing, and that I pick that concern up as part of conversations with JOSC on an ongoing basis, but absolutely committed to kind of monitoring the concern, and I think that would be the appropriate forum where to raise it.
I agree with you on the North West London perspective, but the specific point is about how the investment is going to be funded within Ealing and what the impact is going to be within Ealing. So while I think the wider concern that you've correctly identified, which is a North West London issue and indeed a national issue, is properly addressed through those forums, I do think it's important that we get some feedback to this panel about the impacts of that phase 2 on the future investment when the next time this matter is considered by this panel. Otherwise, there's no point having the contributions from the LMC here this evening.
So I've noted that. I have in my first recommendation specified that we will receive feedback in terms of the proposals. I don't think at the moment we're clear on what the proposals are, so that will be part of the panel's monitoring role moving forward. So that's noted, and thank you, Councillor Crawford. I would propose that we now move on, colleagues, unless there's any other contributions in relation to that item. So the next item on the agenda, item 8, is the adult social care financial position. In terms of the order of business, so I'm going to invite Councillor Newstub to introduce the report. Kerry will then, our Strategic Director for Adult Services, and will set out the kind of detail around the financial position, including some of the challenges that are being faced, and talk about the kind of work plan to contain spend where possible. So I will hand over to Councillor Newstub and Kerry, and please don't take the exit as any reflection on the contribution that you're about to make.
Farewell, colleagues. I'll try not to take it personally, but thanks very much for your contributions as ever. Well, I'm sure as you've looked at the report, it's a difficult position we find ourselves in. The challenges that are well documented nationally around funding for adult social care we are no exception to that. We're seeing increasing costs and increasing demand across the board, whether it's older adults, mental health, supporting independent living, or adults with learning disabilities. Overall, at the end of Q1, we were tracking at 18 million from our budget, and that is fairly significantly above where we expect our forecast to land. Sorry, 18 million in terms of costs. Overall, we've landed about 2 million away from our forecast, and we expect to end the year with around about an 8 million variance from budget. Some of those mitigations that we've seen in Q1 have made that position somewhat rosier. And thank you to the team and to Kerry for the work that they have done to that. But overall, and Kerry will give us more detail and colour, it's a difficult position that we find ourselves in, and it is probably too early to give any particular detail, but I am delighted to say at the end of Q2 we are seeing a slightly rosier picture. We are, thanks to the, not that we're seeing our costs go down, but the work that the team have been able to do to claw back and reduce some of the impact of that have made impact, but we'll be able to share that with you at the next report, at the next meeting, as it has to go through the normal process of cabinet and so on, which is in 2 weeks' time. So I'll pass over to you, Kerry.
Thank you, Councillor Newstub. I was just going to go through the highlights, Chair, and then because I think the questions are probably, there's quite a few, and we know there were some in preparation already. The overall position, as Councillor Newstub has set out, is very challenging. We know the drivers for additional spend in adult social care are the inflationary position which has been experienced across the marketplace, the increased acuity of need, so we're seeing people with significantly higher levels of need coming to adult social care for support. Some of that's being driven by post-COVID illness and experience that there's been a lot in the press about quite recently in terms of the proportion of people who are unfit for work, but also the significant waiting lists and delays that we're still experiencing in terms of NHS waiting lists. If you look to the second slide within the pack, it shows the blue line is the increased daily spend and the orange line is the activity. You'll see that we've got a fairly strong grip in terms of people coming into services and receipt of services. That's through support of people to maximise their independence and promoting better lives, and I'll be talking to you in the next paper about how that links to our vision into practice. The next slide shows the split in terms of the spend, and I think even since we discussed this last year, We're seeing an increased impact in terms of the spend of adults of working age. So that's generally people with mental health needs or people with learning disabilities. And we're seeing increased costs through the inflation within that market space. Just other highlights within the report, which I think would be helpful to refer to. Chair, the spend per day is on page 49, and you can see that the increased spend is starting to plateau, but obviously there's a lot of work to be done in this space. And then the other one that I think is a really helpful slide is one that refers to home care analysis. And you'll see in line with the Council's wider procedures and policy position, we're supporting more people in the community with domiciliary care packages. And we're doing that with greater support to individuals to remain in their own homes, but also trying to manage the size of the support package that is going there to promote their independence. So there were the highlights that I wanted to bring to the meeting, Chair, but happy to take as many questions as meeting's got.
Thanks very much, Councillor Newstub and Kerry. Councillor Kate Crawford first, and then Mr. Cook.
I got it. I'm interested to know why, I don't care about you, I'm very close to him. So there's a couple of mentions of using non-qualified staff. And I'm just grateful that the minimum wage is going up, is going up. That might sort of help the non-qualified staff, but this is quite a sensitive thing to be considering, because what we want is, you know, staff who whatever project they're on, to be adequately trained and with plenty of experience. So yeah, well, perhaps you can tell me in, you know, what capacity you're thinking of using this cohort.
And then Mr. Cook, and then I've got Councillor Baines after that, and then we'll pause for you.
Thank you, Chair. The report is very interesting, the amount of money that you've got available and the way you're spending it. However, I've come across a number of incidents where people are trying to get in touch with your finance department in order to make payments and get fobbed off with some, either they don't get callbacks, and I know one particular case, we're talking about 17 weeks they want to pay, and another case, a new case that's come along, where they've not been told how much the future is going to cost them. And that's very concerning. And then there is a letter that, Kerry, you've signed about how much it's going to cost to actually arrange care, and it's going up 4.5 times its original cost. And there's no explanation as to why this is happening.
Thanks, Mr. Cook, and then Councillor Baines.
Thank you, Kerry, for the report. I just want to know what additional steps would be taken to make sure that to secure sustainable funding for adult social care, considering all of the financial challenges that we have at the moment. So what would be looking at in the future? Thank you.
So I'll pass to Councillor Newstub and Kerry. So there was the Mr. Cook raised the issue around, Councillor Crawford raised the issue around the kind of impact of the minimum wage increase. Mr. Cook raised the issue of payments and also the increase in care charges, and Councillor Baines asked about the kind of challenges and what might help us to overcome those. So Kerry and the use of non-qualified staff as well. Thanks, Councillor Crawford.
I was going to suggest I pick up the last one. There's, in terms of the wider adult social care picture, we're looking at a different government. So we're looking at you know, I'd love to sit here and say we you know, the budget kind of poured money into adult social care. All of us here will be acutely aware that that wasn't the case, and that there has to be significant stabilisation of national budgets for that money to be forthcoming. But obviously we will be putting pressure on the government to move towards whatever becomes the national care approach, because it's very clear that there has to be one. Local authorities across the country are struggling with increased demand and increased cost, and elements in there around the inflationary pressures, but also the essentially deregulated market, which allows for those costs to be you know, very difficult, however we are managing our local market to have control over. I think that's as far as I'm going to kind of talk in terms of the politics. So I'll pass over to Kerry in terms of the specific questions that were asked of him.
Thank you, Councillor Newstab. And just to follow up on the question from Councillor Baines, the next paper we talk a lot in terms of the vision into practice and our strategic direction of travel for adult social care, and how we see the Better Lives Connected Communities framework as our way of coping with the financial pressures that we face within local government and social care, but also promoting independence and the well-being of the community. So it's all right to pick that up shortly. In terms of Councillor Crawford's questions, with regards to unqualified workers, we're very clear in terms of legal frameworks for what a social worker, for the functions that you have to be a qualified social worker to complete. We've recruited 20 unqualified social workers, for want of a better term. We call them ASCers within the service. They're very committed. They're very, a larger proportion of them live locally than we would see in our wider social work force. We're providing training and support for them, and they're a huge boon to the service because of that commitment, because of their commitment to local communities and the service. This came about following the LGA peer review that we had in January 2023, which noted that we had a significantly higher proportion of social workers within the workforce and didn't have hardly any unqualified colleagues within the cohorts of staff. So we've seen this as a real positive piece of learning that we took from the LGA peer review process. But I'm very clear in terms of legal duties that they can and cannot discharge on behalf of the council. In terms of the minimum wage, again, the council's committed to the increase in the minimum wage, and the expectation is that we'll be applying that to all contracts within the community. I think it's the 4th of May, I think it is, off the top of my head, 2025 for implementation. Is that okay in terms of the, yeah? In terms of Mr. Cook's questions, I'd be really interested if you could share the information at some point with me, Mr. Cook, of the individuals. I know that colleagues in the finance and charging department have been working very hard to reduce the waiting lists, and there's been some significant improvements in the last couple of months in that space. But if there's ongoing issues, I can pick them up with the department separately. There's a piece about waiting times for contact and completion of assessment, and then to work through further issues where there's a more complex financial assessment, but I'm more than happy to look into those individual cases that you raised with me. With regard to the question, and I think this links to the ERSCAG's questions, colleagues from Maggie as well, Chair, with regard to the letters that came out to individuals at the beginning of October, with regard to the changes to the charges. This is charges for the arrangement of services on behalf of full cost or self-funded individuals. Up until this change, the council had been significantly subsidising the cost of providing those services for people within the community who are liable for charging. This meant that we were less able to provide other services into the community. The framework is clearly set out within the fairer charging policy for community charging and within the Care Act. and we've not charged the full cost, or not recovering the full cost of arranging services for this cohort of individuals. We think there's something in the region of 500 people will be impacted with change to the charging arrangements, and so far we've received, I think it's just over 10 queries and complaints from that cohort of individuals. We recognise this is challenging for people to experience a significant increase in cost for a service that the council provides. However, we also need to recognise that they've been receiving a subsidised service for many, many years at cost to the council.
Thanks very much, Kerry. Councillor Kate Crawford, you wanted to come back.
Can I work this thing? Just two quick questions. One is, I'd like to know the savings of the recruiting of 20 non-qualified social workers, and whether you plan to increase the numbers over the next, next year, 25, 26, and I would also like to know what the improvement and how you're going to improve the information and advice offer with the, I think it says with its co-production and partnership boards. What's being looked at? Well, considered rather.
Kerry, I'm happy for you to take that.
Is it okay to take the co-production boards with the next paper, because I think that's in the,
sure.
in the
of course,
next paper.
Kerry,
Is that okay?
Yeah.
In terms of the costs for unqualified social workers compared to qualified social workers, the general rule is you can get 3 unqualified colleagues for 2 qualified. So we've got increased capacity. So there's no saving to the service per se. We're expecting to see improved outcomes for local people where we've got more capacity in the system, but we're also expecting to reduce our we are reducing our dependency on interims and agency social work staff, because we've brought in the additional capacity. And the real win from this, councillor, is that if we can encourage the individuals who've joined us in an unqualified position to become qualified, you tend to find that people have stayed with the organisation as an unqualified worker and then become qualified will stay with us for a lot longer than others, because they see it as a commitment and contribution to their professional development. So there's lots of different balls in play here, but that will be the real win if a large number of those individuals are working with us in 10 years' time, and a proportion of them are social workers or occupational therapists. That would be a real win for the community.
So from one Crawford to another, Councillor Dan Crawford now.
Thank you, Chair. Double trouble. Right. The first, so I'd like to go back to the report, the actual report rather than the slideshow or the pack. At the end of the page 44. It says resources have been released to target specific areas of work to reflect the challenging environment for local communities, including increased funding for one-off carers payments. I assume that's meant to be one-off carers payments rather than we're just going to pay for one carer. And then it lists a number of other things. And this is the point I'd like to take up. So all of those things sound excellent, but nowhere in the accompanying documentation does it specify what those things are or what we're putting. So if Kerry or Councillor Newstop could just detail a little bit more on those points. And then the second point is about the budget, and I appreciate that we're still evaluating what elements of the budget we might be able, what growth bids we might be able to make to Treasury colleagues and others. But I would like to ask, the budget, the £250 million that the Chancellor announced to test new ways of working in adults' social care, and the 44 million for growth bids for regional hubs, I assume we would look and evaluate to try and bid for as much of that money as possible, and linked into the peer review, the LGA peer review, and this point made by my learned colleague previously, that we would like to, it's about the framing of this report, because people have responded to this, writing to me, saying, why are we taking unqualified staff? Are we taking away qualified staff and replacing them with unqualified staff? And actually, as I understood it, what we're trying to do is attract people who would like to stay within their local authority and use the opportunity to train within their local area to gain qualifications and therefore progress through the sector. So can I just clarify, that's the point we're making? And if it is what we're trying to do, can we be explicit about that in the documentation and in our offer and in our publications around this? Because that's very easy for people to understand, and that's something where we've identified that there's a problem, and we're putting in place measures to skill up our workforce and retain them, because the key point is retaining the staff. Sorry, I've been a very naughty boy and gone on for too long again, Chair.
No problem. I didn't want to cut you short, but I might if you do it again. So, Mr. Stevens and Councillor Newstep.
In terms of the, you're absolutely right, it's one off, not one of. So I think it was in the region of 400 carers received one-off payments in the 23-24 financial year. It's really important for us to reflect the benefits that informal carers provide to the community, and this was one opportunity for us as an organisation to reduce some of the stresses and strains that they face in their daily lives. It was budgeted for, and it was part of our clear financial programming for the financial year. We've used resources, so we've used one-off resources to support reduction of our occupational therapy waiting lists. It was at the start of August, we didn't have anybody waiting for longer than 3 months for an OT assessment, and anywhere I've worked in London, that's significantly lower. We have a huge demand in England, but the length of wait was low, so that was really positive. We have used some resource to support development of co-production boards to ensure that the voice of local residents is heard and influential in terms of how our services work. And again, that was part of our learning from the LGA peer review, and clearly one of the actions that was set out for them. In terms of our quality assurance for services provided in care homes in the borough, that's been through funding through NHS partners, so additional training has gone into the care home sector, and also infection prevention control, which is really important, especially at this time of year, something that my DPH colleague has just, was very supportive of, and I think that's really important. And in terms of the quality assurance processes within the service, this is in relation to our making the principal social worker a full-time role rather than it being squeezed into other responsibilities that he had. And again, that was a direct response to the LGA peer challenge some 18 months ago. So you can see a clear plan of action from the engagement we had with the LGA in terms of how we can improve outcomes for local residents. In terms of the bids from the budget, certainly we will be looking at that within adult social care in Ealing. We are already piloting some work to reduce the bureaucratic processes that our staff have to complete through the use of AI, and we think that we're on the forefront within that space, and we'll be looking at doing further developments in that area as well.
Thank you very much. Councillor Newstep, did you want to supplement?
No, I think it's worth noting that when presenting budgets, we're so accustomed to only talking about the negative picture that when we do have stories about where we are increasing and bolstering existing services or adding new ones with that capacity, we should perhaps be more explicit about what they are. So thank you.
Thanks very much. So I've got Mr. Crawley from Health Watch, and then I will read out the ERSCAG questions because Maggie's unfortunately unable to join us, and then I think we'll bring the conversation to a close. I think my timekeeping goes out the window when Councillor Steed isn't sat beside me. So Mr. Crawford, over to you.
Thank you, Chair. Thank you for the report, guys. First, I'd like to commend you on the efforts to get people qualified to further their education. I personally am always a champion for that. And I know doing exit and view visits at care homes, those that go through apprenticeship programs and get upskilled are far more likely to stay in that home working, and they are a happier worker for it. My question is, just out of curiosity, yeah, and forgive me if I've missed it, is there a further breakdown of the budget to see, I see like £20 million allocated for mental health. I'm just curious as to what the breakdown is for salary, for maintenance of facilities, things like that. Thank you.
Thank you, Mr. Crawley. I think I added another Crawford to the clan. I think, Kerry, I'm very happy for you to provide further detail on that question, unless you have it now.
I'm unable to provide Mr. Crawley with all the detailed breakdown of the budgets. This is the information that's in this public sphere through what's published. David, I'm sure you and I can have a discussion at some point if it's of interest to Health Watch.
Thanks, and I'll just take the ERSCAG questions now, if that's okay. I'm very grateful to Martin and Sarah, who are in the public gallery as well. So thank you for coming along. And so Maggie has submitted questions in advance. Not sure I'll do them as much justice as she would, but London living wage, can social services confirm that as domiciliary care staff, I think it says all domiciliary care staff receive the latest annual increase, at least £13.85 per hour by May 2025. Care workers in residential care will also do so. We understand that Ealing Council encourages and records London living wage compliant employers. So can we ask how many or what percentage of residential and nursing homes in Ealing pay the London living wage? And then the second question from ERSCAG is, following the nearly fourfold increase in fees for self-funders, we would like to ask what this administration charge covers. Is there evidence and information for self-funders on their financial position, and do they get offered a review to check if their finances are falling below the threshold or if the care package is still meeting their needs? Kerry.
I don't mind. I mean, it's firstly, thank you to ERSCAG as ever for their questions. Around the real living wage, it was one of our key manifesto commitments we were able to meet very quickly, and we can confirm that we will be passing the increase of the real living wage, which we've committed to domiciliary contractors. We estimate it's about 2,500 workers in the sector who'll be benefiting from that. So that's a direct benefit that they have been receiving and will continue to receive. I don't have the precise amount that represents in terms of that investment, but it's in the many millions. For our block contracted care home provision through the PFI, which is about 20% of the market overall, we do indeed also pay the real living wages, around 300 care workers and other staff that will be in those provisions. And when we look at the wider home care market, many of whom we won't be contracting through, but we have an overall management responsibility. 7 of them replied, and 75% of those were paying the real living wage, which is good. We'd obviously like that to increase, and that's part of our ongoing management of the market. Do you want to do the next one? Yeah. Oh, we're going to tag team.
Thank you. And just in terms of the increase for self-funders, I've mentioned earlier in terms of response to Mr. Clark's question, the increase in charging reflects the fact that the council hasn't been charging the full cost of making full cost recovery for the arrangement of services for full cost of self-funders. The increase in charging is based on an assessment and on a proportion of the cost that the council bears in arranging these services for self-funders and full charge payers. As I mentioned earlier, we expect this to be impacting on approximately 500 individuals who have already benefited for many years for the subsidy on the behalf of the council. Where individuals believe that their financial situation has changed and are no longer be liable for the charge, as in that their liquid assets have reduced between £23,500. They should be requesting a completion of a financial assessment, which would be below, if they did have less than £23,500, it would bring them below the ceiling. The charging arrangements would therefore be changed, and I'd encourage people to do so through our financial assessment team.
Can I just add to that, because I think it's a really important point. Our statutory responsibilities are to those, in terms of the provision of the care itself, are, as we all know, to those who have liquid assets that fall below £23,500. Now, until that changes on a national basis, that is, I was going to say it's what we're funded for, but we are underfunded to provide that. So where we are arranging care for other residents, for those other 500, some of them, as Erskine very astutely noted, might well be falling on the cusp of that eligibility, and they must seek a review. And we'd absolutely encourage them to do so. Some of those may well be people who are hugely comfortable but have chosen to have their care, for all perfectly acceptable reasons, managed and provided and sort of sorted out by the council. That in itself is absolutely acceptable. What isn't acceptable is that we're subsidising that on an ongoing basis until the funding arrangements around social care nationally change, and we've all be familiar with discussions around raising the cap or increasing the amount of money that you might have to contribute. That really we have a duty to those more potentially vulnerable but less affluent residents to prioritise that care for them.
Thanks very much.
And there's one more question, wasn't there? Was a question on CQC?
No, we've dealt with that already, but thanks very much for those responses. So I think in summary, thank you for outlining the current financial, or the previous quarter financial position. We look forward to the improved position during the next quarter, which Councillor Newstub's alluded to. And I think in terms of actions and next steps, there was that conversation between Mr. Crawley and Mr. Stevens about the kind of more detailed information. Any other recommendations or comments from panel members before we move on? Councillor Crawford, if it is short, I will take it.
Chair, just to reflect the fact that we had a discussion about we're doing a lot of good things, and some of the framing of the good things we're doing is not cognizant in the report. The report created a misconception among Ealing residents and regular attendees of this panel, and that we were getting rid of qualified staff and bringing in unqualified staff. And I think it's really important that we quash that misconception, which we've done here this evening. But there is a point about putting out the positives, and both Mr. Stevens and Councillor Newstub identified that, you know, they're so used to talking about the challenges that they face, that actually this report, just framed slightly differently, could deliver really good news.
Indeed, and I think I think Councillor Newstub was alluding to the improved position in the next quarter, but I do completely agree with you, and I'm sure the future report will cover those areas. So thank you, Councillor Crawford. So item 9 is the adult delivery plan. I think we move seamlessly into this item, actually, because we've just covered off the kind of financial position. I will come to Councillor Newstub first to introduce the report, and then I think, Kerry, you're going to give us a sense of the progress on the delivery of the kind of your department's strategic objectives. So, Councillor Newstub.
Thank you, Chair. And I think that is an extremely neat segue. I mean, really, the financial report is for examining those finances. But with this report, where we look at the programme of work that is rooted in the more positive things that we want to do, that aren't just focused on money, where we really think we can create better outcomes for our residents, are really contained in this piece of strategic work that was rooted in the LJ peer review in 23, has been reported back on, and this is an update on that. And it really was rooted in reinvigorating the approach to supporting adults in Ealing. When you're facing the challenges that we have been financially,
it is easy to take your eye off the ball in terms of the real hope, optimism and passion that you have to embody the delivery of all of these things, and only focus on the doom and gloom. But this is a really coherent assessment of the golden thread that drives the work of everyone that works within the council and within the team to really focus on improving those outcomes. And it is not a report lacking in self-awareness. It identifies where we are strong and where we think we do well. And I hope that some of those points that that colleagues have raised will come through in this report. But it also identifies some of the challenges that we have. And I think the whole process itself gives us a very clear set of objectives for what we hope and what we want for our residents, whether it's around a more local approach in our 7 towns, whether it's co-production, whether it's increasing the availability and take-up of direct payments, and areas where we can continue to support residents to live independent lives. And I'll point particularly, and perhaps you can talk further, Kerry, around some of the re-ablement work that we've been doing in conjunction with our NHS colleagues. Thank you very much. We've been funding some of it around that work that can really make the difference in someone's life around when they leave hospital. You know, that's a real, as we know, a sort of crunch moment in terms of whether someone is going to be able to return to health and well-being, or whether that is a path into a care home and a much reduced life. So there's lots of work there that isn't only driven by some of those financial imperatives, although sometimes they can have the joyful of landing on both saving us money and being the better outcome for our residents. So this is where we talk about that focus and passion, but also the operational grip and excellence that we have to do in terms of our delivery and where we need to make sure we're effective, but making sure we're also ambitious and innovative in the way that we do it. Over to you, Kerry.
Thank you, Councillor Newstab. And this sets out some of our response to Councillor Bain's questions earlier in terms of what changes and how do we respond to the fiscal challenges, the demand challenges, the acuity challenges that are in the space of adult social care. So as Councillor Newstab's explained, this is based within our continuous drive for improvement for local people. The LGA review in January of 23, clearly setting out a work plan in terms of our learning and development of the services to improve outcomes for local people. We've then threaded throughout the LGA learning, the wider council corporate strategy, connected communities, promoting independence, and stronger voice for people who use our services. As a result of this, we saw some significant improvements in performance in 23-24 from the national data set. So that's in terms of our KPIs, but also our survey results, and that's out within the report. For those of you who are on the committee this time last year, we brought a similar report updating the work plan and our programme of work following the or update, and this is an update for our position. All areas are rated green. The outstanding areas of activity around the 7 towns commitment in line with the wider council strategy, and we're working very closely with corporate partners to define what our approach is going to be, how we will engage with local communities on a 7 towns basis, and that's developing currently. We've recently, or this week, just signed off the strategic plan for increasing direct payments. We see direct payments, this is where people have greater choice and control over how their needs are met through funding through the council. We see this as a real opportunity for us to be able to reflect the diverse needs of the communities that we serve in Ealing by giving people greater influence on how they meet their needs. And the last outstanding action is the drive for equality, diversity and inclusion. And again, this week, it's all happened this week, and we've agreed additional funding to support the adult social care and public health departments drive through some meaningful change in terms of our staff experience of working for the council, but also in terms of how we support communities in terms of the equality, diversity and inclusion agendas. So there's quite a lot here. This is an update on a report that came just over 12 months ago, but happy to take questions, Chair.
Thanks very much, Kerry. I'll come to Councillor Conti and then I've got a question too.
In the body of the report, it talks about at the review that one of the parameters that was below the London average was residents or participants not feeling safe or feeling less safe. And obviously that's quite a, for vulnerable people, that's quite a scary thing not to feel safe. And I just wondered, out of these strategic objectives, which one do you feel most addresses that point? Because I think one of the ones potentially is obviously regarding direct payments and giving those residents the power and the choice to make the decisions that maybe will make them feel more safe. And obviously it says here performance remains steady at 10%. So it doesn't sound like there's been much progress in that increasing. So obviously with these action points, what more can be done, or how else can we empower people to do that? And is there anything else, or because it wasn't clear in the report, was there any particular theme as to why those residents said they didn't feel safe?
So I'll just supplement that. I would be really keen, Kerry, to hear a bit more in terms of that strategic plan for increasing take-up of direct payments. I think it's a really critical issue for us. So would appreciate a bit more detail on that. And I think Councillor Crawford, you also had a question, and we'll take that in this round.
Okay, so I have 3 questions on the 3 areas flagged as amber. So not to chair the meeting from over here, but perhaps we should do those 2 ones, and then if they haven't been answered by the answers that are given, then I'll come.
Yeah, happy with that. So Kerry, I'll come to you.
Thank you. The safety questions are a really interesting one, Councillor Conti, and we've looked at this with the LGA and London councils, and the general view is that how safe people feel in the community is wider than just an adult social care influenceable position. We know that the wider council survey comes up with similar numbers in terms of people's safety in the community. There are challenges because it links into the direct payments piece as well, because it could be assumed that if people are on a direct payment, there's greater risk of their vulnerability within the community. I'll come on to the direct payments question next. Strategically, it's very difficult for adult social care to influence how vulnerable people feel safe in the community if there's wider social issues. And I think that's a real challenge for us. There's a lot of work and a lot of activity engaging with the community through the co-production boards to raise people's awareness of support and services. We have strong response times in terms of responding to safeguarding queries and questions that come into the council, but that wider social community feeling of safety is more challenging for us to deal with as an adult social care department, and it's something that we engage with more widely as a council as a whole. In terms of the direct payments questions, we had, as I mentioned earlier, we've just agreed our strategic working plan for raising direct payments. It's a really interesting area in terms of why direct payments has had such low uptake in Ealing as a council. I've been here for just over 5 years now, or just coming up to 5 years now, and we've not been able to get real traction in this space, and there are a number of competing views as to what the problems have been. We have a very dynamic, responsive domiciliary care market in Ealing that reflects many of the communities that we serve in the borough, and we think that may be a discouragement for people taking the step into having greater choice and control and managing their own services. If you're dissatisfied with domiciliary care support, you're more likely to take up a direct payment as an offer. There's something about how we're supporting and developing our staff to be pushing on the direct payments agenda, and that's something that we're looking at currently. So This is a big push. I agree with the chair's position that this is a really important area for us in terms of the equalities agenda. It's really important in terms of connected communities. It's really important, and in terms of local economies, it's really important. We calculated that 34% of the spend on domiciliary care in Ealing goes to national providers of domiciliary care, which means the Ealing pound is leaving Ealing Borough. If we can significantly increase the number of people of direct payments, the money will stay in local communities to the benefit of local communities. Chair, I propose or suggest that you may wish to consider scrutinising our work plan around the direct payments project. I would think next summer or early autumn would be a good time for us to come back.
Can I just add to that? Because although Kerry and I obviously stand together in all things, I agree that, you know, in part we do have a good and active market, and that may contribute. But I think it's where you put your effort and focus, and that's what we need to do in order to increase that, because our numbers are not acceptable and they haven't moved. And we know that while there may be teething issues either in individual cases or in expanding and offering, that for many people it leads to far better outcomes, and so we need to be better at it, and we will be.
And dare I say that I would question the reported performance in some authorities. There are ways to increase your performance in terms of direct payments which don't have the social and societal benefits that we're proposing through this process.
Absolutely.
That's really helpful, and I will come to Councillor Crawford and then Councillor Ty, but before I do so, we will definitely take you up on the on that issue of scrutinising the direct payments plan. I think it was through specific conversations with ERSCAG. I'm particularly interested in the support that we're putting in place as a local authority for the transition to direct payments, but also very interested in the social value related aspect that you've just highlighted as well, because actually the kind of 34% of domiciliary care going to national organisations, you know, we could be capitalising on that from a borough perspective. Councillor Crawford and then Councillor Ty.
Yeah, so just cut me off, Chair, when you've had enough, because we need to hear from Councillor Ty. Direct payments, I associate myself entirely with the discussion that's just happened, but I have to say I'm very disappointed on direct payments. It was 2 years ago when I was chair of this panel, myself and the Vice Chair, Councillor Steed, went to look at various, either with you, Mr Stevens, went to various 3 London authorities, and I'll correct myself, we went to 2, Brent and Hounslow, and Mr Stevens wasn't able to join us on the other visit that we arranged. There was a strong recommendation of the panel at that point that we accelerate our direct payments offer. We haven't accelerated our direct payments offer. It's gone from 8% to circa 10%. So that might be 10.9, that might be 9.9, I don't know. I looked today at how we advertise our direct payments offer to residents within Ealing who would qualify, and I couldn't find anything on the council's website. This is a specific recommendation as part of the report of the panel, and a specific recommendation as I was a participant in the LGA peer review, which I'd need to declare, Anna-Marie, in terms of declaration of interest. And I'm very disappointed at the lack of progress that we've made. I understand that there are real serious issues, real challenges with that, but we haven't made enough progress. And the points both of you have made with regard to the domiciliary care offer and the activeness of that market are well made, and I respect them entirely. But we should have done more in the two and a half years that have elapsed. So there's that one. I just wanted to touch very briefly on the other 2 Amber-related sector areas. The 7 towns commitment is an established corporate goal of the council. We looked at this again 2 years ago, and the panel and myself and Councillor Steed had some concerns about how we're going to accelerate to get to the place where if each town had a similar offer in respect of resource and transitioning that care offer. Again, we're not there yet. I understand entirely why, because we're remodelling the entire council approach to this. But for one of the bullet points in this to be engagement in your town, your voice, your town, a programme which has not yet launched after, well, sorry, the Your Voice, Your Town, sorry, let me rephrase. Your Voice, Your Town has launched. I understand that, but we're not at the place where members of the public are participating in the Your Voice, Your Town forums that were promised 2 years ago. Now, there's a separate point about how you scale up the town-based offer to make sure that a resident of Acton has the same opportunity as a resident of Southall, and how you deal with specific health-related provision across the 7 towns.
Is it leading to a question, Councillor Crawford?
Yeah, which is, I'd like some more information about how we're going to get there, and it's not cognizant in this report. And the final item on priority 10, the reported actions from the Race Equality Commission. Again, that's an ongoing piece of work. It'd be really useful if we could have more information about that and look at that at a future date. I totally understand that we can't have all of those answers now, but we haven't made enough progress in some of those key areas.
Thanks, Councillor Crawford. And before I invite Kerry and Councillor Newstead, Councillor Tighe, I'll come to you.
Thank you, Chair. And I had a question just on priority 6, talking about the new service model that's in place for hospital discharge. As Councillor Newstead said, it's a really critical time when people come out of hospital, and how they kind of adapt to life again. It looks like the rates look very good, with over 500 referrals and 400 regaining their independence. I just wanted to ask a bit about what does that support look like? Just wanted to get a sense of the kind of support we basically have in place when people do come out, especially those obviously coming out and those who live on their own. So just wanted to check. Thank you.
Thanks, Councillor Newstead.
Well, I'll pick up on a couple of bits. We are the Citizens Tribunal is publishing within the next cabinet, so we will see it next Monday, or Friday rather, as a Labour group, and then more widely it will be published, assuming we accept it. Is a 135-page report on not only the adult social care elements of it, but the entirety of the work from the original commission, and then the Citizens Tribunal, and how that has managed to move the dial or otherwise, and it's not a wholly uncritical lens through which we look at the successes or otherwise of that. So there is a huge amount of work coming on that, and I think it is really crucial that it is included in here, and also included as amber, because I think this is identifying not only the REC as an area where we need to collectively be better on diversity, but we need to have a much broader understanding of inequalities in the work that we do, and that's possibly fair to say across the council, but certainly within our health areas. There's a 9-year differential in life expectancy across our borough. And there are all sorts of different elements which will impact on that. And I'm sure we'll all agree here that that's not acceptable. So I think we need to start looking at the way that we provide services through a lens of equality, and to understand where those equalities lie. And there's lots of interesting work that Anna, who is still here, Anna Bryden has been doing in the public health area, and has been looking at this very specifically to understand what are some of the kind of impacts of the way that we work on the way that communities and people are able to engage with us. So I think there's a lot coming, but it's absolutely right that it's amber, and it points to a need to do more work, which is in significant train at the moment. And we'll hope to be able to report back more. And again, that might be another area for scrutiny further down the line. Your Voice, Your Town is part of a broader approach and step change from the council in order to have a communities in the lead approach. There's been significant elements of training and implementation and building of that, and engaging our local communities. And I think a key element of that is our services, if you like, getting properly engaged in that, and understanding the opportunities and the the ways that our communities, which we know fully well as we do as local councillors and as residents of Ealing, already exist, and making sure that the council doesn't sit separately to those, rather we are embedded in everything that we do within the communities and the offerings that are there, and I'm sure we'll see great benefit from that. I'm going to leave the other questions to you, Kerry.
So there was the one about the pace of change in terms of kind of direct payments, Kerry, and then I think Councillor Ty's point around discharge.
So it is disappointing, and we take that. There's a huge amount of other work been going on across the service, but I take it, Councillor Crawford, I think it's voicing the disappointment is something that we all feel. However, we will bring back further reports in the new year around progress, because we've now started the programme of work. In terms of Councillor Ty's question with regard to priority 6, so the reablement service in adult social care, we have a reablement service of approximately 60 carers plus some managers within the space. We have recently realigned them, so it's like, oh, not recently, it's nearly 12 months ago now. So nearly 12 months ago, they were realigned to support people at hospital discharge. So the reablement service is defined in law. People get up to 6 weeks. Reablement up to, not 6. So often people will expect 6, but it's only up to, where we provide targeted support, occupational therapy input, access to equipment to enable people at discharge to have the greatest opportunity to maintain their independence and not decondition, as the NHS colleagues call it. Approximately, it is a horrible term, but that's what they say. Approximately 80% of our new packages of care come for older adults, come for individuals, come through a hospital discharge pathway. So it's a huge proportion of the new business coming into the service. So in that 12 months, we've seen a 300% improvement in the productivity of the service. So the service is seeing 3 times as many customers. They're providing 3 times as many face-to-face contact hours, promoting individuals' health and well-being, and that's against a background of where people are saying local government productivity is failing. This is a real area of positivity, to go back to Councillor Crawford's earlier point about shouting about what we do really well. So it's a mixture of targeted therapeutic input and assessment, clear targets for an individual in terms of what we expect them to be able to do for themselves after up to 6 weeks of support, and a hugely committed workforce who really want to do their best for the communities that we serve in the borough. Council staff doing the right things for the communities we serve in the borough. Really positive service. If anybody ever wants to spend any time with them, let me know.
Yeah, I mean, can I add to that? I mean, there is a fantastic report which contains lots of case studies from individuals who've which might well be worth, with your permission, Chair, circulating. For me, and I'm putting this into my kind of layperson's terms, it's like if you help, if someone comes out of hospital, if you help them all the things that they need to be able to make a cup of tea for themselves, rather than having a carer come in and do it for them, or making their food, or helping them support the everyday living, that has such long-term benefits that for that individual. So it's very good to see.
Lovely.
I mean, and it sounds obvious, right? But like, so much of care is about doing things for people, and if we actually had to shift that focus to helping and supporting people to be able to do it for themselves, then that's the benefit that we see.
Lovely, and I think there's a really positive story there, so we'll absolutely ensure that that report is circulated. So final round of questions on this item. I've got Councillor Conti and then Councillor Kate Crawford.
Just a very brief question about reablement. Is reablement means tested, that service? Because I had a resident say that their father was not entitled because it was means tested, and I don't know if you could clarify that. Thanks.
Councillor Kate Crawford.
Yes, we are doing some good work with discharge, with discharges. What I'm really interested in is what work is being done before the discharge. The assessments done before the discharge, but there are, I found older residents where clay ponds, for example, hospitals, where they are just left in the bed, and they're not even allowed to push the wheelchair to the toilet, they're put in because they haven't been prescribed therapy of any sort. So they can be there for, perhaps they're a bit longer, or than was expected. So they give up basically on walking, and right across hospitals, if you have an operation, you're made to walk before you really want to. So I think there's that bit of overlap which I would be interested in seeing, where the social worker asking those questions and saying why isn't there a little bit of a prescription for making sure this individual walks, because at a certain age, if they've been in bed for 6 weeks, they're going to lose it, and they won't have that opportunity possibly, and they will have a fear of going back home. Thank you. And if I do not know how to do this.
Carry over to you.
Can I take the second question first, Chair? Absolutely agree with you, Councillor Crawford. The more we can do with clinicians in the hospitals to understand the benefits of promoting independence. However, we do need to recognise they're in a very, very challenging space, and they're trying to move people back into the community as quickly as possible. And there is a degree of risk averseness in terms of somebody coming out of hospital and over providing, which can be problematic, but this function is challenging that. In terms of Councillor Conti's question, so reablement is defined as a non-chargeable service for up to 6 weeks, and this is set out in national legislation. The assessment as to whether somebody is eligible for the service is made by the council. So we have a limited resource, and we have to ensure that people are eligible or are going to benefit from a reablement service progress to a reablement service. We would not refuse somebody, or shouldn't refuse somebody, access to a reablement service because it would be chargeable, because we cannot charge for that up to first 6 weeks. So is that?
It wouldn't be appropriate here, but can I send you the details of that specific resident, and you can look into why? Because their understanding was that they were refused it because it was means tested.
Yeah, absolutely. I'm more than happy to receive that. More than happy, and I'll get back to you.
Thanks very much, Kerry and Councillor Newstead. So I think the key action stemming from that conversation was the more detailed scrutiny that we want to take forward in terms of direct payments. Very grateful to panel members for contributions. Any other recommendations stemming from that conversation? No, I think that that is all. If you wouldn't mind just indulging me for a moment longer, I'd just like to, I'm sure that it has not escaped you that the Secretary of State has launched the NHS Big Conversation. And I think it's really incumbent on all of us as kind of members of this panel, but also community leaders to promote that. So it's a big conversation around the NHS 10-year plan. So if you haven't seen it, it's about the shift from hospital-based care to communities. That's what we've been talking about tonight, from an analog to a digital system, but also that focus on prevention as well. So we'll make sure that we circulate the link so that everybody can get involved in the conversation. But I would really encourage everybody to make sure that they feedback, but also share via social media channels and into the various organisations that particularly Co-optee panel members represent. That would be very much appreciated. A slightly off-agenda announcement there, but hopefully helpful nevertheless. I think that just leaves me then to item 10, which is the date of the next meeting. That is the 11th of March 25. I'm not going to wish everyone a happy Christmas at this stage, but I'm hoping that we will be in touch prior to that. Thank you, everyone, and